let me know when we are good to go.
You're good to go.
All right, good afternoon, everyone. Week 15 and big news this past week. So we've started to see certainly some increased delivery of the vaccinations, and then the governor's announcement last week, which is certainly probably where we want to spend the bulk of our time with the news about additional eligibility. I will say, to kind of start from the very beginning, we've said what was most important is telling people when and where they could get their vaccine. So having a timeline of eligibility based on kind of where we think the supply is a positive step, and we are hopeful that there will be flexibility, assuming that the supply comes through. With a small note that we hope that we don't see a jamming of the system as we saw early on when supply was significantly more constrained. So we'll jump more into that later on. A little bit less positive news. We're seeing some, well, I should probably use different nomenclature, but we're seeing an increase in the positivity rate slightly across the state. And so a little bit of worrying signs about some increased case rate. And so look forward to hearing more there. But we've got another weekend, and let's hand it over to Mr. Powell so we can get the data update.
Sure, happy to. And Jake, if you could share my slides, I will walk through them quickly. We're going to start where we usually do, which is how the COVID-19 situation has changed since mid-December when vaccines became available. Testing is down over a third. Number of positive cases is down by over 2/3. And that positivity rate is down 42% from where it was in mid-December. But on the next slide, we just wanted to highlight this week that rate is up over where it was about 2.5 weeks ago by about a third. So where we were at 3.25%, now it's at about close to 4.5%. It's just something we'll continue to watch. Next slide, please. Vaccinations continue to sort of increase, although it looks like, according to MDH data, there were fewer in the past week than there were in the previous week. That may have been because of the influx of J&J vaccines that we received a couple of weeks ago that took a while to get into people's arms that weren't available to us in the same quantity recently. Next slide, please. Orange is the amount of vaccine that we have that we've used, and blue is what we have basically in stock. That's generally steady since the early days of the vaccination effort. Next slide. This is interesting. The ratio of first doses to second doses has continued to grow since it sort of bottomed out in late February. And so I think most recently it's like 5 first doses for every 2 second doses. So it indicates more people are kind of getting their first dose ratio wise. Next slide, please. All right, we've been looking at this for about a month. Our hope is that hospitalizations and deaths will decline even more dramatically than number of cases or the positivity rate, because the vaccine is going to the people who are most vulnerable to being hospitalized or dying. We see the increase in positivity rate we've seen over the last couple of weeks on this slide as well. The death rate has remained relatively flat. And on the next slide, this shows the same thing, but with the hospitalization rate. Not sure what this says to us at this point, but we'll continue to track it. Next one, please. This is based on the CDC data. Further to the right you are, the more of your population has gotten a first dose, and the higher you are, the more of your population has gotten a second dose. I think as of yesterday, we were 23rd in the nation in first doses and 30th in second doses. And I do want to point out that that's as a rate per population. So it's not a raw number. So we would be much higher than Delaware in the number of vaccines, but we do it as a proportion of the population. Just want to be clear on that. Next slide. This shows the amount of vaccine that the state has that's unused. In the recent month or so, we sort of got to the middle of the states in that measure and remain there. After early in the effort, it seems like we had more on the shelves than many other states. Next slide, please. I'm going to go into some of these in detail, so why don't we jump ahead one more, Jake. So this is the average of first doses being given by race. I have to say, I've got some concerns about the quality of the data on race and ethnicity. So let's take these next two slides with a grain of salt. What this does show is that the rate of vaccination for Black or African American Marylanders has grown dramatically since late February, but is still lower than the rate for white Marylanders and Asian Marylanders. And this is about, I think, 3 people per 1,000, 4 people per 1,000 every day are getting a first dose in Maryland. Next slide, please. Same thing, but by ethnicity. The blue line is Hispanic or Latino. So again, that has grown in the last month, but it still is far short. They're still getting vaccinated at a rate that's far short of the non-Hispanic or Latino Marylanders. Next slide, please. Same thing for gender. Since the beginning, women have been vaccinated at a higher rate than men. That continues. It's probably a little closer than it was in the early days. Next slide, please. This is interesting. Same thing, vaccination rate by age. You can see on that brown line, there was that big bump early for people who are 80 years old and older. That has declined since then. You see the blue line for folks who are in their 70s that grew dramatically about a month ago and has tailed off a little bit since then. And that green line is for folks in their 60s who, as of around February 24th, got vaccinated at a much higher rate than they had been before. That sort of flattened off. You can see for other age groups that's grown, probably just because the supply of vaccine has been growing. So more of them are able to get vaccinated, even the young folks on the blue line at the bottom. Next slide, please. This is for the 8 largest counties. I have data on the other 16 jurisdictions, but honestly, it doesn't, it's not very clear, the kind of signal in the noise of that data. Howard County is the green line. For a while now, Howard County residents have been getting vaccinated at a rate higher than the 7 other largest jurisdictions in the state. You can see Prince George's is the orange line on the bottom left, where they were really an outlier in getting vaccinated at a much lower rate than the other major jurisdictions. They have sort of climbed back to where they're in the pack, but again, that is a gap that continues to grow. So every day, let's see, the gray line is Baltimore County. Like every day, more Baltimore County residents are getting vaccinated, or a higher percentage of them are getting vaccinated than residents of Prince George's County. Next slide, please. This shows the cumulative vaccination rates by those 8 major jurisdictions. We've looked at this for a while now, so you can see Prince George's County is about 15% of the state's population and has received about 10% of the vaccinations, first doses anyway, that have been given in Maryland. Next slide. This shows the other jurisdictions. I think there was one I wanted to point out. Allegheny County is somewhere around, between 1 and 1.5% of Maryland's population. A little bit lower than that in the amount of vaccines that they've gotten, first doses. But Allegheny County, as you can see in the red line and yellow line, had some of the highest death rates and case rates in the state. Washington County, similar story there, further on the left. Next slide, please. So these, give me just 30 seconds to explain these. So the further to the right along this line, it's basically a proxy for time. Every day, a growing number of people in their 70s are vaccinated. That's started at 0% or 1% on the left and has grown to about 70% now. But the height of the dot on these graphs is the rate as of that day. And so you can see, while more 70-year-olds are getting vaccinated every day, they're getting vaccinated at a lower rate since, in the last few weeks. And the next slide is the same thing, but for folks in their 80s. You can see how they were getting vaccinated at a rate of 1.5% of all 80-plus-year-olds were getting a first dose vaccine back early in this effort. And recently that's down to about 1 per 200 per day. And I think about a third of Marylanders that are 70 and older still have yet to get a first dose, if I'm correct. And I'll correct that if I'm wrong about that. And so may want to inquire about that declining rate just to make sure that that 30% to 35% that are left are still able to get vaccinated if they want to. That concludes what I had to share, and I'm here for any questions if they come up.
Thank you very much, Mr. Powell. We appreciate your diligent tracking for us. And let's go ahead over to Acting Secretary Schrader. And I believe we have a presentation. Jake, if you could put that live.
Oh, am I on? Yeah.
You are up.
Okay, can you hear me, Mr. President?
We are good.
Great, thank you, Mr. President. Good afternoon, Senators. If we can go to the first slide, please. There we go. I spent last week visiting doctors and nurses, administrators, and a host of other healthcare providers, as well as faith and community leaders around the state. They are an integral part of our effort to vaccinate Marylanders as quickly and equitably as possible. I saw the joy in their eyes of these unsung Marylanders who are helping us reach further into and expand access to our minority communities, our elderly population, and our population of individuals with intellectual and developmental disabilities, and many of our other vulnerable residents. If I could get the next slide. I was also pleased to see Marylanders who are getting vaccinated in these community settings. When I was in Prince George's County on Thursday, I visited Melwood, which you may know is one of the largest employers of people with disabilities in the country. And for more than 50 years, they've been providing invaluable services to intellectually and developmentally disabled Marylanders who are undoubtedly one of our most marginalized populations. We began working with Melwood in January, and they have now vaccinated more than 500 of their clients. And on Thursday, Melwood's president and CEO, Larissa Kautz, who asked me to say hello to Senator Rosapep, by the way, introduced me to Glenn, who has worked at Melwood for 16 years. And Glenn received his COVID vaccination at Melwood. He shared with me that he was not only eager to get vaccinated to protect himself from COVID-19, but that getting vaccinated enabled him to keep working, which is something he loves to do. And he couldn't be happier. Glenn's story reassured me that our push-pull strategy with trusted community entities to vaccinate minority, underserved, and vulnerable Marylanders where they are is working. If I could have the next slide, please. As you have probably seen this slide, remarkably, it took us 67 days to administer 1 million vaccinations, yet it only took us 27 days to get from 1 million to 2 million shots as the acceleration curve continues to climb. Among those more than 2.2 million Marylanders who have vaccinated to date are vulnerable and hard-to-reach Marylanders like Glenn. And they are among the record 57,550 Marylanders we vaccinated last Friday, and that was the first of 2 straight days of 50,000 vaccinations. They are among the nearly 26% of Marylanders who, according to the CDC, have now received at least 1 dose. And underserved and vulnerable Marylanders have always been a major concern of mine, and the hybrid multi-channel strategy that we created is and will continue to get shots in their arms and every other Marylander we intend to vaccinate. If I get the next slide, please. Last week, we opened another trusted channel to help achieve more equitable vaccine distribution. Primary care practices throughout Maryland have now joined our vaccination efforts, and we began administering vaccines directly to vulnerable populations they serve. With the help of Dr. Howard Haft, who runs our primary care program, we selected the first 37 practices for the program based on their connection to largely African American and Hispanic communities in areas with less geographic access to vaccination sites. Each practice initially received 100 doses and are receiving another 100 doses or more this week. And throughout phase 2, primary care practices are going to focus on vaccinating those with underlying medical conditions that increase the risk for severe COVID-19 illness. I visited 2 of these primary care practices last week, one in Dorchester County and one in Charles County. The doctor who runs the practice in Charles County told me an interesting story. He said that one of his patients, an 82-year-old African-American man who had been a patient of his for years, came in for a routine appointment last week and was adamant that he was not going to get vaccinated. And lo and behold, he left vaccinated. So these are the people we need to and are reaching through this effort. We plan to rapidly grow this program and allocate tens of thousands of doses to family practices in the coming weeks as we get more vaccine. If I could get the next slide, please. Also last week, through the Maryland Health Services Cost Review Commission, we established a community vaccination grant program to support hospital efforts to engage in community-based vaccination efforts. The program is made possible by our one-of-a-kind Maryland model healthcare finance system and will provide $12 million for community-based vaccination initiatives led by hospitals. Through this unique grant program, hospitals will work with trusted community partners, including local health departments, nonprofits, faith-based organizations, and many others, to further increase Marylanders' access to vaccines, especially in vulnerable, underserved, and hard-to-reach areas. Next slide, please. I wanted to talk a little bit about our Vaccine Equity Task Force mobile clinics. So before I conclude today, I did want to mention that Brigadier General Burkhead launched our program last week at hard-to-reach areas, and they are deployed and staffed by Maryland National Guardsmen. Each mobile vaccine bus has the versatility to be used either as a walk-in clinic or a drive-up site to administer between 60 and 160 vaccines per mission. On Friday, I visited one of the mobile clinics at the Mills Memorial Baptist Temple in Salisbury. The parking lot was full of Salisbury residents who received a phone call from two parishioners, and this really was remarkable. Katrina Purnell and her granddaughter personally called more than 130 people, most of whom Katrina said were reluctant to get vaccinated before they reached out to them, telling them about the mobile clinic. By the end of the day, 120 of them arrived on foot, on bicycles, and in cars, and were vaccinated. Bottom line is that expanding capacity, access, and addressing vaccine reluctancy remain top priorities as we move into phase 2, and will help us to ensure that we do not leave anyone behind. Senators, I look forward to your questions.
Thank you very much, Acting Secretary Schrader. Very helpful. I have a couple areas that I want to, some are just short ones, but then let me sort of jump into the probably most important, the increase in the positivity rate. We are seeing slight, which makes sense as things have opened up a bit more. Are we seeing any correlation between the increase, who and where positivity rates are increasing? Is it related at all to where we are seeing a lack of or a lower rate of vaccination?
Well, I think that's probably too soon to tell. Obviously, we set our 2-week period. We're now into the second week early, and by Friday we'll be doing some analysis of the data. It remains to be seen. If you recall, after the wave in the last spring, there was a small wavelet right after that, and then it dropped throughout the summer to the lowest levels we had seen for probably about 4 or 5 months. So we're monitoring this very carefully, but we wanted to at least give it 2 weeks before we jumped to any conclusions.
Are you seeing any type of geographic, take the vaccines out, just where the positivity bumps are happening? Is there any indication?
We haven't seen a lot of change, but we monitor the counties. We monitor by age. We monitor the outbreaks. Obviously, the outbreaks are still down, which I think is a reflection of the vaccinations in the nursing homes and the assisted living.
Right.
So
Okay.
as I said, we're going to be taking a very close look at that data at the end of the week, because that'll be the 2-week period, which
Okay.
usually we said we wanted to wait before starting to draw any conclusions.
Okay. The second big one is the expanded eligibility. I think it's positive that we have the timeline of when people can expect the increase on March 29th. Do we know what the numbers of the March 29th increase are going to be? And then are there escape valves built into the plan in the case that supply doesn't arrive, that there would be a bump back? The big worry that I have is just when we went from 1B to 1C, it's where we saw the demand overload for a limited site. We do have way more sites now, which is great, that are reliable. But the two slides that Mr. Powell showed about the 70-year-olds and 80-year-olds, it's that final 30% of 70-year-olds and 80-year-olds that I'm most worried about. And so just the precautions to make sure that we don't see the increased eligibility wipe out the 70 and 80s. We're trying to get
right.
it.
So that's a great question, and there's 2 or 3 things that we are looking at to mitigate that. One, we're pretty confident that based on where we are, that by this slowly, step-by-step opening to A, B, and C, that we'll be able to, control the valve. And we're watching our pre-registration numbers. Second, I'm also concerned about getting after the 30% that's left in the 65 and older population, which is why we're growing this community-based program. Because I'm pretty convinced, based on what I've seen now, that the community doctors are the pathway to getting a lot of these folks vaccinated. So they're going to have head-of-the-line privileges in any regard. And the third is by using the pre-registration system that we set up now, we have the ability to figure out who's in line and then manage the appointments based using that technique. So the pre-registration is a very timely tool that, as you know, was recently built. Yeah, to help manage that.
In the phases where there is underlying conditions, so like somebody may be in 2A with underlying conditions, it didn't look like those were fully listed out which conditions qualify or not. When do you think that will be specified?
Yeah, we're working on that as we speak. That would be in 2B, and that'll include both the comorbidities, and we're going to put that in the bulletin. We've got our doctors looking at, we just wanted to check one more time because we were using the CDC list. And we may want to make a couple of tweaks to that list before we send it out. And because we had another week, we wanted to take that time to do that. We're also in the bulletin, the disabilities community, SSI, SSDI, and EID are included in that next wave of 2B on March the 30th. So in the next couple of days, we should have. We're going to use the CDC list. We just want to make sure
maybe some minor tweaks.
Maybe some minor tweaks. That's right.
The final question is the status of the Montgomery County MassVac site. Where does that stand?
So we have a list of requests. We've done feasibility analysis on each one of them, expecting some announcements to come out sometime this week. But I don't want to get ahead of the process.
Yep. But it's close.
The announcements are close, and there's a number of requests that are in the pipeline. But again, I don't want to get ahead of the process.
Okay. Thank you. All right, we will jump into questions. So we're going to go with Senator Young, Rosapep, Washington, Lamb, and Eckert if she's able to join us. So we'll move over first to Senator Young.
All right. Thank you, Mr. President. First off, I wanted to thank you for inviting me up Thursday to the stadium, but it looks like we've got the floor that morning and 2 committee meetings that afternoon. So I don't know how I'm going to be able to get up there, but I appreciate the invitation.
Well,
go ahead. You were going to say something?
I said you're welcome. I'm sorry.
Okay. I have about 5 questions. I'll answer them and ask them in 2 sets. The first one is that, is everyone eligible to get a second dose getting it? And if not, why? And with that, testing down. What's the reason for that? And doesn't sound like a good thing to me, but is it? And also, if why?
So on the second doses, we monitor that on a daily basis, and I think you saw last week, we're one of the top states in the country. We're number 6 or so, at 1.7% of the people who are eligible for second doses don't get them. So our discipline process is really working there. As far as testing goes, we're continuing to see tests in the 20 to 30,000 range. If you recall, a year ago in June, we were down around 5,000, 10,000. So we've broken through the testing numbers. And that, of course, when we had the holiday period, we were up around 50,000 tests. But as long as we're in the 20, 30,000 test range, I think we're going to be okay. Of course, people are probably going to get tested less as we get more vaccinations, but that's a good thing.
Well, it looks like AstraZeneca is going to get emergency approval this week or early next week, I would think. So we're going to have 5 companies making vaccine at that point. Do you have any idea how much you're going to be getting and how fast? And you mentioned that we're doing about 50,000 a day. Do we have the infrastructure? Do we have the infrastructure in place to, if the vaccine comes pouring in, to do 100 to 150,000 shots a day? And
that's a great question. If Jake will let me, I've got a slide that shows that, because I know that was asked last week, so we can pop that up if that's okay.
Jake, do you have that available?
Yep, there we go. So this was a question that was asked last week, and wanted to make sure. Right now, we have the capacity to do upwards of 500,000 vaccines a week, and we're going to go beyond that. But as you can see here, you got hospitals, local health departments, mass vax, retail pharmacy, PCP, and a number of those can surge up even higher than to take us well over 500,000. Based on our estimates of what we might receive, somewhere in the 300 to 400,000 range, we've got plenty of capacity. And then you can see across, our plan has been for quite a long time now to build each of these channels with with goals for each one, and then what the value of each channel is. So we're very confident that as we get more vaccine, we're ahead of the curve and in being able to do more vaccines every day.
Well, real quick for a final one related to that, you said you're looking soon to be getting 300,000 to 400,000 vaccines a day. Are the feds doing any updates with the other companies coming on? Have they given you any indication that they're going to rise beyond that, where if you can do 5, 6, 7?
Well, Novavax is another one we're hoping for. So that, Novavax and then, of course, AstraZeneca. But even without those two, with J&J producing at the rates that we've been promised, and then the increases in Pfizer and Moderna, I'm expecting, again, until we see it, it's a promise from the federal government, at least 300 to 400,000 total doses. That would be first and second doses.
Okay, thanks. I think you're muted, Bill.
Sorry, I just wanted to clarify, Senator Young, you said per day. That was per week. Is that right?
Per week. Thank you. Yeah, did I say per day? That was,
no, I think
no. You said per week.
Yeah, you said per week. So our likelihood, March 29th, that kicks off 300,000 per week. We think will be available, delivered.
Hopefully, again, that was, it could shift a week. Here's where the little nuance in the language is. If sometimes the federal government will say available for order, which is not necessarily available to ship. So it could end up being the following week, the first week of April. We're trying to give everybody the benefit of the doubt, which is why we're being careful in how we're saying it. But they're, the available to order in the week of the 29th, which would be, of course, next week.
Got it. Okay. Thank you. Senator Roosevelt.
Thank you very much, and thank you, Mr. Secretary, for all that you and your folks are doing. I thought the chart that you just put up about the value propositions of the various channels was very well thought out and really helpful. What it doesn't have is what I asked for last week, which is actual metrics related to how we're going to meet the goal of vaccination on demand by President Biden's goal of the 1st of May. I would think, given that framework that you laid out, you should be able to, or you need to be able to, sometime before the 1st of May, be able to attach actual metrics to that. So I want to ask first, where are you in actually coming up with a plan that goes through May 1st when we get to vaccination on demand with real metrics by channel?
Well, on the left-hand side, and it doesn't have the numbers there because we're still tweaking them, but we're estimating hospitals can do about 135,000. They've given us some information. The local health department's about 115,000. MassVax is currently about 95,000, but we expect that to do even more as we continue building that capacity. We also have the retail pharmacies. We're estimating those very conservatively at about 50,000, but we think that's going to be a lot more. And then, of course, the primary care physicians, about 35,000, and I'd like to see that go up to 45 or 50,000 a week. So it remains to be seen. So we have some minimum and maximum ranges for each of those channels. And then, of course, I forgot to mention the mobile vax is a smaller number. That's about 7,000 a week, but it goes in and finds the hardest to reach people. So it's each one of those channels has a value proposition, as you mentioned. So we have numbers that we're tracking toward, which is how I'm very confident that we're going to be able to handle and if you think about it, if we can do that number, of vaccines a week, without, we get to maybe 1 million a month then. So that would be terrific. But we've already proven we can do 1 million in 27 days. So I'm optimistic that we're going to get there.
Well, I'm hopeful that we're going to get there. I would hope that by next week you can come back to us with actual numbers. You gave us some orally, which I really appreciate, for capacity. But to be at vaccination on demand on May 1st, you have to estimate what the demand is going to be by May 1st, and you got to work backwards from that to see how many have been vaccinated, how many will be vaccinated each week until then. Because otherwise, we're going to get to May 1st, and the governor and the president of the United States say it's vaccination on demand, and then we end up saying, oh, it's not really vaccination on demand. It's vaccination on demand like on June 1st. You see what I'm saying, Mr. Secretary?
Right. It's very possible, Senator, and I'm not saying this is going to happen, but it's very possible as we get through the month of April and we keep vaccinating at the rate we're vaccinating, we may find ourselves in the month of May and June in this pull model. It's a question of when is the demand going to recede, and then we're going to have to pull people in. So that's
I get
unknown.
that. Believe me, I get that. There's a marketing job after we get everybody who wants to do it now. But what have happened is what happened in the first 3 months of this, where the governor says all these people are eligible and they can't get the vaccine. So I would hope that we learn from that experience as we go for the next 5 weeks. We actually attach numbers to these things. So when we get to May 1st, the president and the governor's commitment to vaccination on demand is real instead of theoretical. So I'd appreciate, I think all of us would appreciate if you could come back to us with actual metrics over the next 5 weeks. I'd like to switch to my other question, repeating from last week. Prince George's County is still under vaccinated compared to the rest of the state. Where are you on coming up with a plan? I appreciate the individual things you're doing, and I appreciate the visits. I think that's very important. It's good that you're out there with the troops. That's exactly what a leader ought to do. But we still need a plan with metrics about when are we going to get Prince Georgians up to at least the average level in the state. I love Howard County. I'm not even saying we got to get to Howard County's level. I just want to get to the average. Then we can go to Howard County's level. But we need a plan to do that. When do you think we're going to have that kind of plan?
Well, we have got 2 or 3 things in the pipeline that we're not ready to commit to yet, but every day we're doing new things in Prince George's. As you saw, the governor was at First Baptist Church. We're expecting that to bear fruit, and of course we put aside the 2,100 doses for Six Flags. But we've got some other things in the pipeline that are not cooked yet, and as soon as they're ready.
Mr. Secretary, it's always a good idea to go to church. So I don't in any way say it's not a good idea to go to church. But we need scale, and we need scale rapidly. We need a plan to get to scale. So appreciate it. Thank you, Mr. President.
Thank you, Senator. Senator Washington.
Thank you, Mr. President. Thank you, Mr. Secretary, and I am happy to see the mobile units. We're happy to see the centralized line. We're happy that you're understanding that it's less about hesitancy than access. But these are things that this body and others brought to you on day one. So just imagine where we would be in terms of vaccinating the most vulnerable if we had gone by what the experts say how we should go. But I actually wanted to just start, Mr. President, if you don't mind. I sort of was looking with some volunteers in my office at some of the daily reports, actually kind of all of them, and our meeting documents. And, you know, the Secretary talks about data and the use of data. And I see a lot of complicated and somewhat excessive statistics. But I still see that if we're using data to drive our decisions, and why, if the highest rates of death of COVID-19 are within Black communities, that's on page 12 on one of our March 8th data, March 8th report, or in our populations of 80 plus, and that was again from that same report, you know, why are we continuing to deprioritize those vaccinations? And of course, we're moving to phase 2, and I'm very concerned. And some of what I see is that the efforts to vaccinate have really been focused on reopening the economy, and that the vaccination system that has been developed seems like it's supporting white, affluent, tech-savvy, working from home Marylanders are getting their vaccines first. And an example of that is when you look at the move from phase 1B to 1C, we hadn't really doubled down on making sure that our 75 plus populations are adequately vaccinated. So, so this is actually now to the Secretary. I was looking at some of the previous reports about the number of doses administered for the max vaccination sites. And that was the latest report I looked at was March 10th. And it stated that the numbers were collected and reported by the health system administering the mass vac sites. So, however, the latest COVID vaccine summary that was available on March 15th, the mass vac site reporting out entirely. So with opening several new max vac sites across the state, not currently reporting accurate data on these sites, it looks like it's being buried within the health system data. Can you really help me understand how this is giving you an accurate picture of vaccinations across the state?
So let me see if I understand your question. You're asking about the mass vac sites and their production individually?
Well, I guess I'm asking about where the data is. So I'm just looking at the data you've given us. So since,
right,
you know, we tend to get answers from you the night before our meeting, I thought, well, why don't I go back and look at some old answers and then ask you about them. So I'm looking at the number of doses administered for the mass vaccination sites, and you can come back later with the answer, but I just want it on record. That it states those numbers were collected and reported by the health system administering the mass vaccination sites, right? However, what we got for March 15 on our latest COVID-15 vax summary had taken the mass vaccine sites reporting out entirely. So this is an answer I want later, not just on the fly today, but
Yeah.
you know, really how with opening several new vax sites and now you're expanding, we're notably to our local providers, how we're really getting an accurate picture that's helping us drive the decisions to move for, you know, from 1C to 1B and how we're going to continue to manage that.
We'll take that back and pull something together that helps,
Yeah,
because we're
yeah.
working on the same problem. We want to make sure that the mass vac sites are reporting in a body so that we have a picture of that. And then
your data just doesn't match up.
Yeah, we'll pull that together for you. Thank you.
Also, Mr. President, I just have a couple others. It has to do with the lack of inclusion and partnership in community-based centers. I was looking on page 24 of your last report, and I'm glad you're going to up that, but it's less than 1% of all the vaccines administered. So that's something that really needs to be upped. And I was looking at on your page 28, you were referencing a news article on directions from the Biden administration. Like we've asked, you know, where, you know, what guidance are you using? But in your documents, you reference a news article. And I was wondering, do you not have direct communication with guidance from the CDC? And so why wouldn't you reference communications from the CDC as a reason to move, you know, to the next priority group? And then additionally, kind of in that same section, you are able to collect age, race, gender, and ethnicity and county administration, but you're really not choosing to collect priority group designation and verification. And I'd like to know about that. And just finally, Mr. President, something else that I just have to mention is that thank you for the scope of work, you know, for the contractors, and specifically what was interesting, I draw people's attention to attachment A. So the scope of work that you wrote, where you said specifically you asked for vaccine workflows for the quote unquote typical resident. And when we see that term typical, I kind of read that as code for white, affluent, tech savvy, and you've got zero mention of building equity into the efforts there. And specifically, when you look at the leadership of Ernst & Young, it seems to be primarily completely devoid of any diversity. So we really would like some accountability on how, you know, the millions of dollars that you're spending on contracts seem to be completely devoid of equity and building equity, and simply going to churches and simply having PSA announcements is just not at all sufficient to address the growing equity that we're going to see as as phase 2 expands. So I know these are a lot. I'll email them to you, and thank you, Mr. President and colleagues for giving me this opportunity. But it's there's quite a lot of concern I have about how we've proceeded over the last 11 weeks. And so thank you.
So I will do this. I'll ask Mr. Powell to follow up with you, Senator Washington, to put those questions down in specifics
Yes.
that we can follow up. Does that work, Senator?
Yes, absolutely. Thank you.
Okay. Senator Lamb.
Thank you, Mr. President. I wanted to follow up on the President's remarks about the fact that a third of Marylanders above the age of 70 have not gotten a dose. When you actually boil down to the numbers even further, it looks like it's less than 40% of Marylanders age 70 to 80 are fully vaccinated. And when you look at those that are above the age of 80, only 45% are vaccinated. I don't think this is due to just vaccine hesitancy. You need to get these age ranges back up to a much higher rate, maybe about 80%, given that they are representing an over proportion of the deaths and that they are also the most vulnerable populations. What are you going to do specifically to get them to a much higher rate of, say, like 80%? Because right now it's still falling pretty significantly short. And this is particularly important because, as Mr. Powell pointed out, the rate of vaccination of these groups has recently begun to decline. It's actually slowing down, decelerating.
Yeah, so Step one is we are making week in and week out progress, and we're focused on this population to get them vaccinated as quickly as possible. We are moving to the community-based providers because we believe that's where we're going to get the next large bump in vaccinations, and I think we're starting to already see that. The other thing I've asked my team to do is to break down the 65 and older into genders, because one of the things I'm concerned about is when we look at gender, 2/3 of the vaccinations are women and 1/3 are men. So I want to take a look to see if that gender gap translates into the seniors, and then we're going to have other strategies to reach those folks. So we're tracking it every day. We're vaccinating people 65 and older every day. We're not going to leave anyone behind, regardless. When we open up to phase 2 tomorrow, we are still going to be focused on going into because I think this is going to be a pull, not a push. Just pushing back.
With all due respect, I'm not hearing many specifics there, and that's what has me concerned, because we want to ensure that everyone who is above the age of 75 or above the age of 65 in groups 1B and 1C can get a vaccine before you fully open up to everyone in group 2. Otherwise, the older folks will always lose out. And I understand the Southwest model, but the Southwest Airlines model that you cite and have cited in the documentation, but the group 2 people are always going to be able to run through the terminal faster and get to their gate and ultimately get in line and get a seat faster than those that are in the 1B and 1C older population. So I'm concerned that I'm not hearing anything about specifics as to what you're going to be doing for these folks.
If I may, so we've been partnering with Secretary Kramer, with the Department of Aging. We're organizing vaccination clinics in the vulnerable areas. I'll give you an example. Safeway has agreed to be a clinical provider at a clinic that we're starting at the Senior Center in Bowie. That clinic is projected in another week and a half, and we're working with the town of Bowie with an emphasis on zip codes 20715, 20716, 20720, and 20721. That's the starting point for that particular one. Then we're working with Baltimore County to provide additional vaccinations in their targeted zip codes, and we're coordinating with each of the local agencies on aging in each of the jurisdictions. And Safeway has identified a location at a senior center to vaccinate about 400 per week in Baltimore County. Similarly, in Harford County, as a jurisdiction that we think they need a more immediate support, and we're working with the local agency on aging there and identifying clinical partners to reach into that jurisdiction.
Can you tell me what proportion of the nursing home residents and assisted living care facility residents in the state are not vaccinated at this time?
As far as we know, very few, except for folks who still need their second dose.
Can you get us a percentage?
I don't have it right now, but we can give you that.
Okay.
We only have about 24,000 people left that are going to get their second dose from the long-term care pharmacy program. So
I'd just like to know how many of those in these nursing facilities have chosen not to get vaccinated, right? Because those are overproportionately a higher older population.
Right.
There was a recent report in the Baltimore Sun that the Charles County mass vaccination site is actually vaccinating more Virginians than Marylanders. And as you know, the allocation by the feds is by state. So having Virginia residents vaccinated at our Charles County mass vac site is not only skewing our data, but it's also making it harder for Marylanders to actually get vaccinated. What are you doing about that?
Well, that was really a misleading article. It was 6%. We have had about 5% out-of-state vaccinations consistently for the whole period. The rate in Charles County was low, that is correct, but the rest of the doses were to Marylanders from other jurisdictions, which is why we set aside doses for Charles County at that mass vac site. So that was a very misleading article.
Okay. Well, it is concerning that a lot of our efforts are still going to vaccinate out-of-state residents. Is given what the president cited in terms of, rising number of positivity rates and cases, is there a rate of vaccination that we should hit before we reopen further? Are you willing to commit to a specific vaccination rate or percentage before we open further at this time?
Like I said, we're going to be evaluating the data. There's a 2-week period from the time we reopen. That'll be this coming Friday, and we're going to monitor that. Obviously, we're in a race to get as many people vaccinated as possible, because that's how we're going to stop this thing. And we've got at least 23% of the population has received at least 1 dose, and we're at the rate we're going to move very quickly.
Okay, so it sounds like you're not willing to commit to a specific number at this time. My last question has to do with the Ernst & Young contract. In the contract, in the scope of work that you provided last week, it said that one of the project deliverables, one of 3 specific ones mentioned in the scope of this work, is a report that outlines the assessment of the state's vaccination program, which must be completed within 7 calendar days by Ernst & Young. This must include discernible and actionable recommendations in order to optimize the vaccination program. Now, I believe the Senate President had asked you specifically for that report last week. There was also a question in the written questions that were sent to you. However, what we've received in response from your department does not include that specific report. So I'm wondering if you can, again, provide that specific report, why you're not providing it, why it's being kept secret.
So we did not ask them for a report to put on the shelf. We asked them for recommendations that could be implemented immediately. So out of that, we started immediately with better management of the supply chain and allocation process. One of the first things they came up with was the 95,000 doses that had gone to the federal government, the military, that were really not our doses. They also have been bringing us best practices for our max vax sites. So as soon as they came on board, they've been helping us figure out how to run those more efficiently. So it's not, the report was not something that we would ask them for 100 pages and put it on a shelf. This was embedding them. This was a concept of embedding them into our enterprise and driving action. And so that's what they've been doing. And they've been delivering a lot of value in that regard.
But the deliverable says it's a written report. And so I'd like to see the written report. It's one of 3 deliverables cited here out of a $4 million contract from Ernst & Young. If you have completed all of them, then the completion rate should be 100% of those recommendations. There should be nothing to hide if you're willing to provide that report.
I think we have a misunderstanding about how this kind of project works. This is very similar to the way the federal government works. These are staff augmentation contracts that provide expertise on the ground to help us deliver the process. So we'll take that back, but I think we have a misunderstanding of how this actually works in the real world.
We'll follow up on this this week in the follow-up, Senator Lamb.
Thank you.
We have to move along to Senator Eckert. Senator Eckert?
Thank you very much. And I guess my concerns were probably addressed first. Thank you, Mr. Assistant Secretary, for coming down to Dorchester County and the shore on Friday. Sorry I couldn't be with you. I'm getting the same question. You know, I still have people who were 80 and 90 who haven't got the vaccine yet, even in our rural counties, and yet younger people that they've talked to are able to get it. The next round are those people who may be 60 to 65 who have compromising medical illness that I would consider a priority. So I've been telling people to go see their primary and make a case, particularly if they're in a place where they're moving around that they might be at risk. Because I think those vulnerable populations are critical to get at least one vaccine, if not both. I think all of our facilities, developmental disabilities, psychosocial rehab, nursing homes, I'm pretty sure ours are pretty well addressed. But it's the seniors in the very rural area. And I know the vans will help that we're going to be employing. So we appreciate all that effort, but it's still that same issue that I've heard, how can we open up to the next level if we know that people in the very first group aren't all vaccinated? Thank you.
Right. And if I might add, we were at Dr. Nar's office,
Right.
And she's doing a great job.
Right.
Our data, we're tracking 65 plus by county, by numbers. So in Dorchester, there's the population of 65 and older, 7,063, and we still have about 2,622 to reach. So we're looking at how do we begin to micro target those people. I guess that's a strategy. I should have mentioned that earlier on the question. One of our strategies is micro targeting the 65 plus based on data that we have, and then going after those targets. So that's our next step.
Right. And we have lower numbers of seniors than like Talbot. I think Talbot, Worcester, and Kent are our highest number of seniors.
Yeah, Talbot has 11,057.
Right.
And 3,462 still need to be vaccinated. So we're managing at that level of detail. And the next step, that we're working on it now, is techniques for micro-targeting those individuals.
Fire companies, thank you.
That will be helpful. Well, thank you, Mr. Secretary. I have two quick summary things. I did just one clarification. The current capacity today in the current system, our goal is to get to 500,000 a week. I thought I heard the governor say that it was 100,000 a day is where we are. We have the capacity for 100,000. Do we have the capacity today at 100,000 a day?
100,000 per day is the target. That's what we're driving towards. Right now, we can reach up to 500,000, which is slightly below that. But as we open up some of these new sites and as we continue to grow the primary care physicians and the pharmacies and the other channels, we can get, he's pushed us to say he wants 100,000 a day. So that's where we're heading.
But today we are able to do 500,000 per week. We have the capacity to do it.
Yes, exactly. And so when those doses come, we're ready to go. We already have that's why we've been building the infrastructure. So, but it's not just, as I said earlier, it's not just pushing out tens of thousands. We're going to have to go in and pull people, which is why this micro-targeting strategy is so critical.
Agreed. Just a final point, positive news. Our vaccination bill passed the Senate unanimously today. Look forward to continuing to work on that. We hope that we're hitting the end game sooner than later, and that having these metrics has been extremely helpful. And I think having that path through the summer will be very helpful as well. So just wanted to put that on the radar. We do have to run because we have to run to our next event. Thank you again. Week 15 we're in. Look forward to seeing you next week, and let's root for a successful week. Thank you all.
Take care.